I would, so one time I said, oh, I'm going to be on TV, and they watched it. And then like the second time it happened, I said, hey guys, I'm going to be on TV again. And they said, oh, on the boring station, which was, I love kids for that. They're just,
Sounds about right.
yeah.
Yes, indeed. Yeah, I can't imagine even asking my kids to watch this YouTube video, but maybe someday they will and
Right.
enjoy it. All right, well, thanks everyone for joining. Susan and I are excited to have you here, and we're excited to have Bert Plant from Beacon here to talk about all the great dashboarding work they're doing. This is the last in our series, three-part kind of special guest series where we've had our ASO partners come and present all the great work they're doing to help just provide background as well as context and also any idea generation. So thanks everyone. And let me see if Susan, I don't know if there's anything else you want to welcome or say before we dive in. I know you have a lot more to say in a little bit.
Get off mute, of course. Just quickly, great to see everybody and looking forward to a robust discussion, particularly with some of the updates that we've done in terms of the transparency data. So just glad to be chatting with folks today.
Yep. So we'll kind of dive right in. I think Susan has been working to get things up in terms of the cost transparency data, which I know is in a static form, and we discussed that previously. And so just took a snapshot of it, and hopefully folks had a chance to take a look. And if you haven't, please make sure the link was sent out previously. And if you need another one, but it's on the cost transparency dashboarding website for us. I'll turn it to Susan because I know there's some short-term refinements that are going on and a few other things that she would like to highlight but just we're excited to be able to present this and to hear from you guys. There'll be ongoing work in this space.
Yeah, thank you, Brad. And I think that's really is the key to this, is that it's ongoing work. It's very much iterative. So as folks know, and you stated, it's static at this point, but we're certainly looking at how we can, even for the few data points that we presented at this point, are there some ways that we can move that into something that would be more interactive and dynamic? Some of the short-term refinements is that we are expanding some definitions on the document that we posted the other day. So that should hopefully be up in another day or so. So trying to add a couple of things that hopefully will better explicate some of the information for folks. We're also working with our fiscal folks on adding some additional cost and expenditure points. So hopefully in the not too distant future that we'll be able to have some additional representations of some data, particularly with some other eligibility groups and some other cost areas that folks are often very interested in. So that is very much in the works, and very similarly, how some of those data can be put into a more of a dynamic dashboarding format, as well as our other, making sure these kinds of data are also on the Connecticut Open Data Portal. So we want to make sure that we're doing this as kind of complementary to that site and the expectations for the related to the state plan. So just want to let folks know that this is ongoing, and we're not just kind of, oh, you got these, we're good, we're moving on. We're very much, looking at how we can refine what we've presented, and also I think importantly continue to expand and iterate and make sure that we're giving folks information and data that's of value and use to them. So.
Thanks, Susan. And I think we welcome at this point and I know a few folks sent some emails or comments already. So if you'd like to kind of rehash, you're welcome to, but if you just want to share any initial thoughts, reactions to this, I know, like Susan said, eventually hoping to, move this to a similar to our PeopleServe dashboard, where we have it at a more, we can do our stratification, do our deep analysis and cross tabulations, et cetera. But any initial thoughts on how this is presented, even in the static format, welcome that at this time.
For the two bottom bar charts, do you scroll down and see the key, the legend? I was just curious about like what the blues and the oranges mean, like on the actual website.
Yes, you should be able to
Okay.
in the, I can't, I don't know if I have it pulled up at the moment. Susan, you might.
Yeah, I don't know. It might have gotten truncated on it, so that may be what happened. But we did try to replicate the same color scheme throughout. So even though it is, looks like it might have gotten truncated, that the colors that on the average quarterly expenditure by program should carry out. So we wanted to try to make sure that for that purpose, that visually we would stay consistent. But it might have gotten truncated. But the updated version, if it hasn't been corrected, will do so.
I think this is really great. I love how you made it uniform without throughout. And as OHS is considering how we can make our information with our benchmarking more public, where I think just using some of your design things as a guide and just looking at that, I think it's going to be really, really helpful. My only other question is for people who are looking at it, do we define Husky A, Husky C, Husky D somewhere, just so they know? Yeah.
That's being added, yes, the definition, we're creating an appendix page. It's just being reviewed presently. So that is one of the short-term refinements that hopefully, if not by the end of this week, hopefully by the earlier part of next week is good to go.
That's awesome. This is great. Thank you so much, Susan, for sharing.
No, thank you.
And thanks for the questions. Those are really helpful. And,
Yep.
We keep refining. Obviously, this is a fairly, it's not the dynamic kind of eligibility or people serve dash, but obviously it's still useful information that people are probably interested in. Susanna, go ahead, please. Oh, you're on mute, I think.
Sorry, can you hear me now?
Yes.
Okay, great, sorry. And I'm not a cost expenditure expert, but one of the things I think I would be interested in, and I don't have any idea if this is possible, is sort of spend on things like primary care or pregnancy-related spend as compared to hospitalizations. Is that, I don't think that the ACD differentiate in that way. Is there a plan or an ability to track sort of where that spend is going over time?
Yes. To a degree. I mean, there's some challenges obviously in our definitions of some of those, but we do already do some of that. And Susan's already related to some of the additional data that we are going to be working on trying to incorporate, but definitely understand the interest in trying to be like, okay, well, how much do we spend on X? There is, again, making sure there's a few components to this where we historically haven't necessarily defined. And so there's some effort that we'll need to go into,
And I think that
or go ahead.
the ASOs do some of that as well. As you'll see,
Oh, yeah.
Some of the things that I'm presenting, we can look across levels of care and then group levels of care into lower and higher, et cetera. But again, to Brad's point, there's lots of different ways to define those things. So, we just need to be agreed as to what we're grouping together and what falls into each bucket.
Yeah. And thanks, Brian. A lot of that, again, I think between the other two presentations and the one you'll hear from Bert today, a lot of this is done at even the cost level, but as we're trying to do this for public accountability, we have to go back and define some of it. And I think that we have discussed having a single source of truth in terms of the data and how it's being normalized and how then we're eventually displaying it and defining, what are we considering primary care? Are we including urgent care in that definition? Are we including OBGYNs and certified nurse midwives, or are we not? And since and obviously this is being done kind of external, but right next to us with Beacon and with CHN and Benacare, but we obviously kind of need to do this as well and be very explicit about how we're defining it and make sure we describe that as well, which is work in progress.
Brad, sorry, I haven't updated my Zoom version here at the office, and so I can't formally raise my hand. But I wonder if it's worth thinking about a per capita version of the expenditures. One of the questions that I might have if I were looking at this is how much of the kind of, what proportion of the fluctuations are associated with changes in enrollment. So it might be helpful to have something that kind of standardizes that.
So like a per member per month
Yeah,
type
yeah.
of thing or something.
Or per member per quarter or something like that.
There is, isn't there, Brad, wasn't there one of the representations? Was that not the quarterly PMP by program?
Yeah, it's this is Ann. I'm on the site. I can see it. It says average quarterly PM by program, and then quarterly enrollment and PM comparison.
Great, great. Sorry, I was just responding to what was on the screen there, but
Sure.
on the site, yeah, perfect.
But certainly if there are other things, you know, Chima, from your perspective, we'd certainly welcome your thoughts. I can't promise we'll get it, you know, but definitely would be interested to hear it. So thank you.
Sorry, everybody, I got booted from my own Wi-Fi apparently, but I'm back.
Well, we assigned you a lot of stuff, Brad, in that time. So I'll talk to you offline about all the things that we've committed you to do.
Thank you. I hope you took some good notes, Susan.
Copious.
Grace, I think up next.
Yeah, so one thing that may have come up in past meetings, but I don't remember, but you know, with the great data that's here, for people that may be new to looking at these things, or just because it's interesting to have the department's perspective on reasons, you know, obviously the past couple of years, COVID is probably one factor in some of the data you put out, but your own interpretation of data as it's presented, some of the reasons behind the trends, I think would be helpful, especially for people who are looking at it for the first time and are just interested in why some of this might be happening.
Appreciate that. And I think one of our challenges is obviously the making sure that we have explanations and not making extra things be the holdup. Obviously, I think both Susan and I would love to have had this out even sooner, obviously a long time ago, but recognizing like the more things that we have to get done and approved, the slower. But I think as we iterate, that's a great point. It's like, okay, well, what's an explanation? When did the public health emergency start? When did we have higher eligibility to do that? Well, there's going to be a big change after the PHE, public health emergency, ends, and there's going to be a change. And if folks aren't familiar with that, it may be confusing. So you're right, there's need for some explanation. Some of it's just very clear like that, right? The PHE occurring, and then when does that end, and then how does that affect eligibility? Some of the other interpretation is, you know, other things that we would have to probably internally look at. Susan, I don't know if that makes sense. If you have anything else you want to.
No, that absolutely makes sense. I think we can certainly, you know, talk with folks about how we can include that moving forward.
I think Ben and then Karen.
Thanks, Brad, and hi, everybody. My question was related to Chima's comment, and just for those top two line charts, I was a little confused by what's meant by average. And are these in fact total expenditures and enrollments, or are they an average? And if they're an average among what group?
Thanks, Ben. Karen?
Sorry about that. I lost my unmute button. I was just going to add to what Grace said. I think the idea of putting some markers on the charts for major milestones, like for example, if the legislature has changed eligibility limits, if you were doing a longer look back, but also potentially linking to the presentation that DSS does every year for MAPOC, because a lot of the analysis of budget changes and enrollment changes gets shared there, or some of it does. And that might just be a way of not adding work, but sharing more information with people who are interested.
Yeah, and we're definitely interested in sharing that type of information, Karen. So thank you for raising that. And definitely, I think is something we'd like to, we'll be looking to include as part of this moving forward. Susan, I think that's kind of, I think the next part of this is probably including that some of the stuff that we're already publicly
Yes.
previously reported, we just haven't included here yet. Great. Well, thank you guys for your comments and thoughts. Anything else anyone would like to share, feedback, comments, welcome them. And if anything strikes folks later, we're happy to receive it electronically as well.
Exactly.
Again, some things that Susan would say, like we can do, some of these things are easier than others and will take longer time than others to do.
Yep.
But
Yeah, definitely keep it coming. I mean, I know that sometimes, you got to let it sit with it, and or a particular need or ask might appear. So, obviously we're always receptive to hearing from you guys. And, if it's something that we think we can do, we will definitely put it in the queue to try to do. But certainly welcome folks' opinions and thoughts and ideas.
Great. Well, with that, just kind of provide some updates. Actually, Susan, do you want to, I'll let you take it away.
Yeah, and definitely jump in here, Brett. I'm going to more kind of focus on the some of the people served and eligibility kind of phase 2 enhancement and expansion. So our last meeting, we I think live demoed, or was it a meeting or two ago, live demoed the eligibility people served dash. And as we had talked about earlier on, when we were starting to kind of phase some of this out, and we shared it with the advisory board, that we would be looking at doing enhancements and expansions. And so we are having those conversations about what can we do, at least with kind of even the base document the base data that we have, different filters that potentially that we might be able to add, as well as some additional representation. So one of the things that you're unable to do, because you can only pick one year, one period of review, is to see if can we create something that will allow for some trending. So if folks are wanting to self-serve and for particular periods of time and seeing, some of the trajectory of the data. So that is something that we are looking to do, and we'll be working with our developers on whether or not that's something that we can do with some of the existing data. So again, trying to maximize the underlying data set, but we're also working with other divisions that within the agency to also see if there are data that we can potentially also put out in a more dynamic, interactive way. Because it makes me really think very much about when you're talking about kind of social determinants of health. It's some of those other services that I think it's important for us to have information out there that folks can look at. So we are also looking to include some of that. Now I'll jump in, Brad, but if you want to talk a little bit about some of the quality dashboarding progress and related team expansion work, I'll lateral back to you.
Sure. Thanks, Susan. Yeah, just to say, we actually have, so Bert and team actually have already sent some HEDIS measures from their perspective. And that's what we're initially planning from a quality measure, is really just to try to publicly have, a standardized measures that we can explain, and that we've been working with our ASO partners to help produce in a similar way. And so the hold up for us on that end is actually a contracting issue with NCQA that CHN is just about to finalize. And so once that is done, we can formally publish the static quality data, but there's been a few barriers in terms of the contracting aspect of it. Again, we have it beaconed in the Benecare, so the dental and behavioral health data already. Actually the data, the HEDIS data from CHN for the medical ASO is pretty much ready to go. We just need to be able to formally have the contract signed, or they will, so that we can do it. And I think that should be done in the next month or so. So that will be the next thing. Again, it will be static for now, but that will at least allow us to share that out publicly, and that'll be a good next step. Obviously, there's more to come, but and then in terms of ongoing work to expand the team, we're still trying to flesh this out. This does fit, I think, Susan and I have been talking a lot within the larger construct of our data and analytics work within the department. Obviously, we have our ASO partners have, Beacon and Bert's team have extensive analytics ability. The question is, how much of this do we have to, as we're doing some public reporting on some of this, how much do we need internally, and other questions. So this is an ongoing kind of internal conversation that we'll continue to have, and hopefully have some more information at the next meeting. Any questions or thoughts about any of this? Susanna. Oh, unmute.
Sorry, the double mute gets me every time. So maybe it was embedded in there, but I'm not sure. We had talked some about future phases, and I know you're doing all this work to get the initial information up, but there, sort of how and where on the timing do you see going back to some of the measure concepts that maybe weren't as simple to implement, but feel important and starting to sort of think about getting those out in the world?
Great question. I think one of the things that we are, and actually have been messaging about still, is trying to make sure we can get data from other agencies to help with some of this, because some of that will be needed to do some of the aspirational measures and requires us to be able to easily transfer data back and forth, which there's some issues. And actually Beacon does this on their own for other initiatives already, where they're getting data from state agencies to do some of this. But in terms of for DSS to receive it and then process and do other things, there's a few steps. We haven't historically, we do receive data, but we historically haven't necessarily, it will take us a little while to incorporate it, is my guess, but it seems like an important step. And the other piece to this is again, trying back to our ongoing analytics and other work, is our own data infrastructure and pieces that we're very interested to see improve, so that things like this are, I think, maybe a little bit easier on the technical side for us to execute on, very necessary so that we can actually do some of this more aspirational work that we have previously said we need to be able to do this. It's just making sure we have the infrastructure and the person power to be able to execute on it. But appreciate the nudge, and you guys are welcome to continue to nudge us on this and check in on it. So thank you. Susan, please feel free to add anything or change anything.
No, I think you've encapsulated kind of where we are. Yep.
All right. With that, let me turn it over to Bert Plant, who I think again will, present some of the really great dashboarding analytic work that Beacon's been doing for years now, and probably a lot of the data that you guys are familiar with is coming from his team. And I will turn it over to you. Let me make sure you can share, or I may need to change that. And I will stop sharing mine. All right, give it a shot. Let me know if you can.
Yeah, it looks like I can. So let me go ahead and do that. Yeah, can you see my screen?
Sure can. Yep.
Great. So I do know a number of people in the meeting, but I'll just sort of quickly introduce myself. So my name is Bert Plant. I'm a psychologist by training. And I've been at Beacon Health Options for the past 8 years. And when I was hired into Beacon, the state was not happy at that time with the state of our analytics and reporting and so forth, and really gave us a charge to improve things. So that's really what I've been working on for the past 8 years. And, I think we've made a lot of progress, but as you guys know, this is always a continual work in progress. And, we continue to look at how we can improve our reporting all the time. And so what I'm going to be doing today, these are the various agencies that we partner with through the partnership. But I'm going to give you an overview, just very briefly, of who we are. I think most folks know who we are, so that'll be very brief. Talk a little bit about the various data sources that we utilize for our various reporting. And then really the point here is I'm not going to be spending a lot of time on each slide in terms of the content of it. It's really just to give you an idea of what kind of reporting do we do, what kind of things might be able to be transferred over in part of this transparency website, and just what our capabilities are and how we report and look at the data. And so we'll be looking at some of the membership and utilization reporting, some of our health equity analyses, the financial reporting that we do, our quality metrics and performance standards. I'll show a little bit of static view of our population profile, which really helps us to do kind of population health analyses. We have some provider analysis and reporting programs. I'll explain what those are and just the kind of data, rich data that we're sharing with providers to improve care. And then I'll touch briefly on, many of you may be aware that we were recently awarded the right to renegotiate our contract for the next 3 years with potential 2 more extensions. So we're very happy about that. And we're almost completed with those contract negotiations. We hope to wrap it up very soon. But within the new contract, there's new reporting and new things that I'll just touch on briefly that we're in the process of developing as we speak. And then just wrap up with some caveats about the data, at least from our point of view, and allow time for questions and answers. So very brief overview. So as was mentioned before, the Behavioral Health Partnership is a integrated public behavioral health system. And the 3 agencies are the Department of Social Services, Department of Children and Families, and Department of Mental Health and Addiction Services. And they each provide input into what our priorities are, what kind of data they want to see, what improvement projects we engage in, et cetera. And our role is as the administrative services organization, and we do a number of things, including utilization management. We promote clinical best practices, provide supports to members and providers, do various performance improvement and quality management functions, and then data and analytics that assist with kind of all of these. And the primary goals set out for us are to improve access, quality of care, outcomes, and member experience. So that's really what we're focused on in a sort of at a high level. And people can feel free, it's a small enough group, if you want to chime in at any point in time and interrupt me to ask a particular question, that would be fine to do that. If somebody else could sort of manage the hand raising and all that stuff. Thank you, Brad. So just quickly with our data sources. So we do integrate data from various sources, the 2 chief ones being all the claims data that we receive from DSS and their contractors. And, you know, each of the ASOs gets the full claim set with all of these various components to it: medical, pharmacy, behavioral health, dental, et cetera. And we add to that our authorization data. So we have an authorization process for services. We collect additional data in the process of that, and then we integrate those together to give a clear picture. We also consume data from other state agencies, DCF and DEMIS primarily. And we are now kind of been embarked over the past number of years of pulling in other additional data sets, some of which are related to social determinants of health. And so we do get housing management information system data. We're in the process of working with DSS to obtain TANF and SNAP data. There are many other, there's a project that we did under the governor's task force to pull in other data sets like incarceration data, arrest data, and so forth. And we find that building out from the healthcare data set and looking at other social services is really helpful at better understanding the population that we're serving and what their needs are. So I'll go quickly on to Medicaid membership and utilization. So this is just a couple of examples of some of the reporting that we do for membership. And so this slide on the chart or graph on the left is showing various cuts of the data. So all members with duals, all members without duals, adults with duals and without, and youth with and without. And then we have included, as we were talking about previously, some of these lines here that identify ACA implementation, change in eligibility criteria, COVID-19, as things that really impact utilization at various times or increase membership. And over here, we can also disaggregate it to look at membership by race and ethnicity, by age, gender, language preference, and things of that sort. So we can look at the membership in a number of different ways, and we can view it over time and see what kind of trends there are and try to explain where we see changes. This is just another similar type of graph showing, this is cutting it by benefit groups. So, we can look at Husky A, the single, and we report it as a percentage and also as the total number for the year. In terms of what Brad has raised before about the definitions and so forth, we have slightly different manner in which we count numbers of membership than from what DSS does. So our numbers don't always jive. And so if somebody appears once in a period, I think what DSS does is the average membership over a particular period. We have anybody who's been seen within a month or a quarter or a year. And so we sometimes get some different numbers, but they really are, they should track each other pretty well. For utilization, I haven't shown a lot of utilization reports here, but we can look at every level of care and look at their trends over time. And, here on the left, we're looking at a specific set of services related to autism services for the autism population, and showing different kinds of services for like a diagnostic evaluation, behavioral assessment, various types of service delivery, and can see how those trend and over time. We also demarcate, I forget what this red line is because I took it from something else, but we can, put points in there about when we think significant things happen, either with the system or with utilization. And then for this one on the right, we're just showing we can drill down into utilization by particular programs, but also looking at things like not only just standard utilization, but things like how many episodes get delayed in discharge, and what is the average delay days, and can track that over time as well to look to see where our services potentially getting sort of bogged down, or where the throughput is not excellent. This is another thing. This is really showing telehealth utilization prior to and then during the pandemic. And the top line is showing the percentage of claims for behavioral health services that were not telehealth. And this first indicator shows that like 97% were not telehealth. When you look at the bottom, that reflects what percentage were telehealth claims. And you see how it changed significantly at the beginning of the pandemic and has been pretty much sustained at about anywhere between 10 or 11% since then of all behavioral health services delivered by telehealth. This is critically important during the pandemic for, I think, reasons people are familiar with. This is looking at behavioral health emergency department stuck volume. So we do reach out. This is not in claims, but we reach out every day to every emergency room a couple times a day to find out how many individuals are stuck in the emergency room and what kind of service they're waiting for or recommended for. And we can track that over time. And you can see here, there's been a spike recently, and there's been obviously a lot of attention paid to the impact of the pandemic on the youth population, which this is mostly focusing on, and that, what can we do to address this? Obviously, the legislature has just passed a ton of improvements for the children's behavioral health system, and some of them focus specifically on crisis centers and other things. So our data can be used to support those kinds of initiatives and the need for those kinds of services. We've been doing since pretty much 2014 a lot of analysis and continual improvement of our reporting and monitoring on health equity and disparity. And we've really been trying to step back and say, let's really not have health equity be this one little report over on the side, but let's have it embedded in everything that we do so that we can explore the impact of disparity and health equity on all of our reporting. So again, it's a continual work in progress. We do an annual summary every year as part of our standard reporting. We look to embed demographics and social determinant data points wherever possible in any of our dashboards or reporting. We try to use the best practice of displaying data for maximum insight, meaning that some methods of displaying data can really underestimate or hide disparity and others can enhance it. And so we've paid a lot of attention to the methodology we use for reporting. We try to employ advanced analytic processes to improve reporting. One example is in the area of where there's unknown data with regards to race and ethnicity and some of the things that we're doing there to try to improve that reporting. We're looking at it across access, quality of care, experience, and outcomes. And, ultimately, the data really has to be used to develop interventions to improve health equity and reduce disparities. We try to include a diversity of opinions and participants in all that we do, because that helps to inform us of what's needed and provide different perspectives. And one of the things I'll talk a little bit about in an upcoming slide is we employ data governance strategies to guard against bias, because you can unwittingly perpetrate bias in your algorithms or in your data management if you're not careful. So here's an example of some of the reporting that we do. This is for antidepressant medication measurement or management for HEDIS. And it's looking at the adequacy of treatment during acute and continuation phases. And what you'll see here, I'm not sure if it's big enough for you to see, but essentially this dotted line is across at the group that is best offered or has the best rate, which in this case is white at 66.8%. And then these other populations, unknown, other races, Black and Asian, all fall below that, although Asian is pretty close. But we see that generally what we've observed is on most of the quality measures, not all, the Black population has not as good quality indicators or not as good quality outcomes as we would like to see. And so we track this every year, every time we do these. We also can look at it by Hispanic and non-Hispanic. It's interesting for antidepressant medication management. Actually, Hispanic group is the best off, which was sometimes counterintuitive, but we find that at times. So this is just an example of the kind of reporting that we can do for looking at disparity. This is kind of a different way to look at and explore disparities. This is our population profile, and each of the metrics here. So we have geography in terms of county, where people live by counties. We can also filter down to zip codes if we wish. We have housing status, we have gender, race and ethnicity, age groups, and we do have primary language indicator as well. And we can look at DCF involvement and some other things. There's a whole second half to this population profile, but essentially if we apply any of these filters, it refilters the entire dashboard so that we can see, what is the demographic breakout of Medicaid membership in Hartford County if we click the county in this map. If we click those who are homeless and click this housing status indicator, show us what are the demographic or the age distribution. It can also tell us things about total spend, about top diagnoses, et cetera. So it really allows us to drill in on any subpopulation. We can look at those between certain ages who are non-Hispanic Blacks, who live in a particular area of the state, and get a ton of information about those subpopulations. So this is a very rich tool. We also have our provider analysis and reporting dashboard where we give this data. So we can sort this data by like all hospitals or by each hospital and have specific data for them about who they are serving and who they're serving better or worse, so that they can make some changes internally, and we work with them a lot on best practices, et cetera, to accomplish that. And one of the things I mentioned before is, a lot of algorithms are used in healthcare. Recent research has demonstrated that quite a few of them are biased because the data in the system itself is biased, and that most have not been tested and may be worsening disparities because, they may be selecting individuals for a particular program to help with, let's say, someone who has diabetes or has a particular mental health problem. But if their selection process is leaving out certain groups, then those groups aren't going to have access to this improved or intensive care. So we've been focusing a lot on this and developed efforts to correct for fairness. We've developed some expertise, and we are in the process with our parent company of implementing an algorithm governance process to make sure that all the algorithms we're using are fair and we're not continuing to perpetuate the biases that are in the system and in the data. Financial reporting, again, we have a dashboard. There are all these filters here. We can look at higher or lower levels of care, telehealth, various age groups, demographic filters, et cetera. But this is just showing for all levels of care. And I think it is, in this case, focused, it's on all. And this is the total expenditure for the year by year. We can also drill into it a bit more to look at the total expenditure by levels of care. The top line here, in case you're wondering, that is the highest in terms of total expenditure is outpatient treatment, which is kind of surprising to people. It has a low rate, but it's the most predominantly used service for behavioral health. And so we can track different levels of care, and we can sort by higher, lower levels of care, et cetera. And we can also disaggregate the expenditures by race and ethnicity. And this is showing that, the highest group on a per member per month basis is the white population, followed by Black, Hispanic, unknown, and then Asian, having the lowest expenditures on a per person basis pretty consistently over time. We have a lot of quality metrics and performance standards. So we use HEDIS measures, as Brad was speaking of earlier. We also report for the department on the core measures that CMS has, many of which overlap with HEDIS, but some depart in some important ways. We use some quality metrics from the National Quality Forum. And then we develop a lot of hybrid specialty metrics based on particular programs or needs that we identify that aren't addressed by a standard metric that already exists. We have in our contract 15 performance standards that really look at how is the ASO performing in some of its basic functions, things around call management and timeliness of that, the timeliness of our authorization process, how we're processing denials, appeals that both members and providers can apply, and our complaints and grievances, tracking them by different groups and looking at resolution of those. So these 15 different standards subject us to penalties if we don't meet the threshold. And we have that data as well in a standard report card every year. Again, just going back to that population profile, I showed you this view before, which has all our demographics and how we can sort that to look at specific subpopulations based on, all the factors listed here: age, language, housing status, geography, et cetera. But we can also then see all this other data when we filter it, which is what are the primary mental health, substance use, and medical disorders that various subgroups are demonstrating. How often are they going to the ED or using key services like outpatient or inpatient services? What's the prevalence of various medications for substance use disorder treatment, annual spend, and spend by different categories. So there's really a lot of data here and a lot of power in this population profile. And now I'm just going to move on to our provider analysis and reporting program. These are just some of the dashboards that we use. So what they are is they're a set of performance improvement programs organized by level of care. So for instance, we have inpatient psychiatric level of care. We have withdrawal management level of care, home health, intensive outpatient, et cetera, psychiatric residential treatment facility. And we bring together all the providers under Medicaid that deliver those services. We create a set of metrics that allow them to look at who they're serving, how well they're serving them, what some of their standard performance indicators are related to length of stay, readmissions, et cetera. And we have these custom dashboards, and we can look at how the whole level of care is functioning, but we can also look at how each provider is functioning and create incentives for them to improve their performance, either through some kind of value-based payment system or through a incentive program that reduces the amount of authorization that they have to seek from us. So if you're performing really well, you don't have to obtain authorization. And then there's gradations within that. So we're nearing the end here. Some of the new reporting in 2022 and 23. We have been doing provider surveys previously, but we discontinued those at some point. But we will be initiating a survey of providers to get their sense of how is the system working from their point of view. We've been asked to do a pharmacy analysis to get a sense of, what are the top behavioral health medications being prescribed? What are the adherence to those medications look like? What are the costs associated with certain medications, and to give us ideas about how we can perhaps better manage that. We've been asked to do a retrospective COVID-19 impact analysis. What's been the impact of COVID on the behavioral health system and the members that are served by behavioral health services? We're also going to be renewing a member survey, so getting member input on how they're being served under the behavioral health partnership. And then we'll also be looking at the adequacy of the provider network by looking at, how far do most people have to travel to get to one, and are there enough in terms of the population that might use services, and where they're located. So kind of a density ratio reporting. So just a few caveats, not all the data that we have is suitable for public posting. Some of the provider dashboards that we have do get into PHI. So obviously those would not be appropriate. We also, we really don't want to post dashboards that have even any link or access to PHI, because if there was a security breach, we want to protect against that occurring. Some cases, there's volumes and volumes of reporting. We really need to be high enough level that people aren't going to be just overwhelmed with hundreds of pages of reporting. I think interpretability of reporting, I think the group already brought that up before, which is you do need to provide a lot of explanation and coaching. Otherwise, people will, I think, have a difficult time understanding what the data is, and could come to erroneous conclusions if they're not provided with some context and education about what the data is. There are various reporting formats, live dashboards, static reports, narrative reports, et cetera. And last but not least, one of the things to consider is occasionally, very occasionally, do we have proprietary components, either algorithms that we purchase or that our other parts of Beacon or Anthem have developed and that we're using locally. Those would have some proprietary protection components in them. And I think that's what I had. So I know I zoomed right through all of this, but if folks have any questions or comments, I'd be glad to respond.
Thank you, Bert. Very much appreciate it. And if you can, I'll take the blame for the zooming through, since I think Susan and I kind of harassed you about that a little bit. So you did, but thank you. I think obviously just a sample of some of the work that Beacon's been doing. And but welcome questions or comments from anyone at this time.
Thanks so much, Bert. That was really great to see all the different data you collected. I'm especially interested in your social determinants of health.
Yes.
And it seems like you have some that you're collecting and some you're planning to collect. And do you just kind of you must have an individual identifier for each Medicaid recipient and then kind of track it?
Well, in some cases, what would be ideal is if we had their Medicaid ID number across all these data sets. Oftentimes we don't have that. And so we do a, sort of a propensity matching approach, a number of algorithms that we use to match one person to another. It gives us a probability score that they're the same person. And we've been, pretty successful with using that methodology. I think we're on a quest to obtain more data. Some of it is through certain projects, like we have the INC project, the Integrated Care for Kids project, which is a integrated behavioral health and medical services sort of pilot program that hopes to go statewide in 4 or 5 years. In that one, there is a lot of additional data. So some DPH data, some data from public school systems, child welfare data, et cetera, that we are pulling in and matching and then integrating the data sets. So, and I think there's, some data points at DPH that would be very complementary and very helpful. And so that's kind of what we're doing, but thank you for that.
Yeah, it's excellent. And we're at OHS, we're also trying to look at how we can get data sets from social determinants of health, like more with community, share data with them. So it's interesting to see what you're doing over in Medicaid. So thank you again.
Thank you.
So Bert, thanks for sharing. I'm always floored by the just breadth of work that you guys are engaged in there. It's very, very cool. Can I ask, so as it relates to kind of provider feedback, how do you guys deal with patient risk and risk stratification and the like? Or do you just kind of send it to the providers and let them figure it out?
No, so we develop some of our own predictive models and risk models that we then incorporate into our PAR programs. And so, one of the things that when we wanted to start with inpatient psychiatric services as one of the most robust PAR programs that we have, and we wanted to sort of move in the direction of holding providers accountable for how they're performing on various metrics. One of the first things we heard is that, we're serving a much more difficult population than, so, after many years of hearing that, we actually worked with the providers over a number of years to develop a model that took into various severity indicators and predicted a length of stay based on their severity in these like 20 some odd indicators that we include in our model. And the providers participated in and provided us with some really good suggestions, some of which were some of the like highest loaders in terms of what that do. For example, something like an individual who's receiving electroconvulsive shock treatment would have to stay longer because the protocol for that has to be done over a certain period of time. And so if somebody's a candidate for ECT, then you would need to increase the length of stay that would be provided to them. And so we have a predicted and an actual length of stay, so we can see how well are they managing it. And then it kind of levels the playing field across providers based on the population that they're serving. We also do things, we know that individuals, when they transition from the youth system to the adult system, this transition youth period is often one where they drop out of care. So we developed an algorithm to identify who is at highest risk for dropping out. And then we are sharing that data with DCF and with DMIS for those individuals who are transitioning from one system to the other to look, who do we really need to focus on or be concerned about in terms of that transition. We have a algorithm that helps identify a first episode of psychosis. And then we have a special team that outreaches to them. So there are probably 5 or 6, maybe 7 different risk type algorithms that we're using as part of our provider analysis and reporting. And, there's an interest in doing more. One of the ones that we're currently working on is related to methadone maintenance and who's most at risk for dropping out of care prematurely. And that's something that we're going to be rolling out in a new PAR program this year. So there's a fair amount of, actionable data that we're providing to the providers so that they can see these are the individuals that we have to, do additional outreach or pay attention to. Does that answer your question?
Yeah, always just one quick follow-up.
Sure.
The concern, of course, with public reporting or the tying of bonuses or payments to this data is that you get a provider response, right? That providers start avoiding certain patients or the like. Have you seen any kind of behavioral response from providers in your system? Is there a shifting around of? Yeah, go ahead, Bert.
We have not seen that, partly because we track it. So we can see, because we're looking at these severity indicators and we're looking to see what the population that each provider serves looks like. And, we could see if there was a dramatic change in them, in their diagnostic profile or in not accepting anybody who's in contact with the criminal justice system, or things of that sort. We kind of have the data to call people on that if we see it happening.
Wonderful. Thanks, Bert.
Other questions, comments, thoughts?
That's my thought. Thanks.
Yeah,
again.
and I'll just say, I think, we are obviously a lot of the work that's happening at Beacon and our ISOs are on dashboarding, just trying to, again, take some of the great work that they're doing, figure out how we can make sure we're publicly reporting information out. Obviously, there's some different focus of the effort that's being done, including risk identification, including population health and management, that are maybe less about the focus of some of this work as we, you guys help craft a lot of this.
Right.
And
I do think also, on the spend issue, one of the things we learned in constructing our PM dashboard, because we're trying to tease out what are behavioral health expenditures and what are medical expenditures. And while that on the surface might seem like an easy thing to do, it's really very complicated. And, as we appreciate how behavioral health impacts medical care and medical care impacts behavioral health care, and that so many people have, challenges or disorders across various classes of disorder. And the way the coding in the claim system is, it's not always so clear. So we do have to come up with a lot of definitions and a lot of, sometimes arbitrary decisions about what's in and what's out. And those are critically important because they could dramatically change the numbers that you see depending on which bucket they go into. And so I think there's a lot more work that could be done in that area. I think, we're at a pretty good place. We're comfortable with how we're reporting that. But, it is very interesting. So like one of the questions, Brad, I'd be interested in your perspective on sometime is that the question of like Alzheimer's and dementias, is that a behavioral health? You could say, yes, definitely. That's a behavioral health disorder, but we're not really managing those services in any way to be able to have an impact on that and the spend and utilization associated with it. So it's, it's just kind of an interesting question as to where you draw those lines or what's included or what's excluded. So more discussion on that, but.
Agreed. Yeah, I think highlights that kind of back to that single source of truth of data and what are our definitions, and making sure that we make sure that whatever we're trying to make as available is very clear. And this can get very messy very quickly. I think as anyone I think a lot of us know, as we start getting into the data, we have to make, like Bert said, sometimes quite arbitrary decisions, or at least we try to follow standards as much as possible when those exist. So definitely a lot of work that Bert and the Beacon team have already put in to do this, and the means that we have to do a lot of work if we're going to even get to part of kind of what they've built out, so that it is clear what we're talking about and what we're reporting on.
Yeah, the last thing I've just mentioned, Brad, is that, and I know that you're aware of this, but each of the ASOs has their own website where they're posting data and reports and things of that sort. So, I mean, that's also a resource if people want to learn more. And everything that's posted, I just know, at least for the CTBHP, is first approved by the contract managers for that before it goes up there. So,
yep.
That's
Yeah, that is helpful if there is interest. There is a lot of various reports on that CTBHP Connecticut Behavioral Health Partnership website. And I think, Susan, I want to make sure to see if you wanted to add any more color or context to this.
Yeah, I think we're good. And Bert, thanks for the presentation. It was nice to see.
Thanks, Susan.
Any final thoughts, recommendations, not just for this can be for either prior discussion on our cost reporting or just overarching recommendations or thoughts? Well, I think, again, we just appreciate your guys' continued engagement, involvement as we work through this. Right now, we are slotted to meet in July, and I actually don't know if we have that meeting booked. I will confirm with Jody, and if not, we will work to identify the next few meetings out and look forward to, well, anything that we're able to get out ahead of time or modifications, we'll make sure to alert you to in a similar format where we send an email and ask for any written feedback ahead of time and ask for your review before the next meeting. So we'll continue to do that.
And thank you all for the opportunity to present here. And obviously, if there's a particular topic or something else in the future that we think we can be helpful with, please let us know.
Thank you, sir. Susan, any other final thoughts, comments?
No, none for me. Thank you.
All right. Thanks, everybody. Appreciate it. And we'll be in touch to make sure this next meetings are scheduled. All right. Bye.